Before entering my patient's room, I'm going to gather all my equipment. I have my stethoscope, my pen light, my tongue depressor, and also I would have a otoscope, and then I would also have my reflex hammer. I'm going to walk into my room. Knock, knock, come on in, perform hand hygiene, introduce myself. Hi, my name is Lucy Kao. I'm the student nurse for the day. Can I get your full name and date of birth?
Diego Aguilar, July 1st, 2002.
Perfect, Mr. Aguilar. I'm going to be doing a head-to-toe assessment with you today. Is that all right? Perfect. I'm going to provide some privacy for my patient. I'm also going to explain the procedure. I'm going to be auscultating you, so listening to your heart sounds, listening to your chest sounds, and then I'm also going to be touching you. Is that okay? Perfect. And at any point, you just let me know if you're in any kind of pain, okay? Also, I do need you to say yes to being videotaped. Perfect. All right, I'm going to begin. So on inspection of my patient's head, his head sits at the midline of the body with no signs of micro or macrocephaly. His head is normal cephalic. I'm going to don my gloves. I have my patient's head in front of me. I'm going to start palpating. Is that okay with you? I'm going to come on in, palpate my patient's head with no masses, lesions, or tenderness, and no discomfort felt by my patient. Next, I'm going to be inspecting my patient's hair. On inspection of my patient's hair, it is black, smooth, well-kempt, and groomed with no signs of male pattern baldness, alopecia, and then there's also no signs of pediculi, lysis, or nits on the borders of my patient's hair. Next, I'm going to be going down to inspecting my patient's facial features and his symmetry. Patient's nasolabial folds are equal bilaterally. His palpebral fissures are also equal bilaterally. The outer canthus of my patient's eyes and the pin of the ear are aligned correctly. Patient's face is nice and relaxed with no signs of tics or any kinds of Bell palsy or cerebral palsy. I'm going to be inspecting my patient's facial features, assessing cranial nerve 7. I'm going to ask him to do a few facial expressions. I'm going to ask my patient to puff his cheeks. Go ahead and purse your lips. Smile for me. Smile with your teeth. Frown. Can you raise your eyebrows? Can you wrinkle your forehead? And then could you whistle for me? Perfect. Facial exercises indicate a intact cranial nerve 7 with no signs of difficulty when performing these tasks. Next, I'm going to be inspecting my patient's eyes, but the external features. I'm going to ask my patient to look at me. Patient's eyebrows are fine and coarse throughout with no signs of alopecia. There's no crusting or debris around the eyebrows. Patient's eyelashes curl upward and the bottom ones curl downward. No signs of exudate, chalazions, or styes on the outer structures. Next, I'm going to be asking if I could pull down your cheek, if that's all right. I'm going to pull down and inspect the conjunctiva. The conjunctiva is pink, vascularized, no signs of drainage, edema, or any redness. The sclera is white, clear throughout, no signs of jaundice. The cornea has no hazy or cloudiness to it, no signs of cataracts or glaucoma. Then I am inspecting my patient's iris. It is brown throughout. There is no signs of discoloration. Next, I'm going to be performing a few eye exams on you. Is that okay with you? First, I'm going to test for accommodation, so go ahead and just follow this pen light as it moves further and then closer to you. Patient's eyes are accommodating as they constrict and dilate. They dilate when the object is further away, and they constrict when it is closer to them. I'm going to be assessing my patient's corneal light reflex by asking him to look at something behind me, and then I'm just going to shine the light 12 to 15 degrees above him. The corneal light reflex indicates a bilateral symmetrical light reflection on the corneas, no signs of misshapen cornea with no need to perform the cover-on-cover test. Next, I'm going to be assessing my patient's direct and consensual pupil dilation. So I'm going to ask my patient to go ahead and look at me real quick. I'm going to shine a light in your eyes. Patient's eyes dilate. They are equal, round, reactive to light, and consensual. They both constrict when light is shined upon them. There's no signs of mydriasis, mitosis, or anoscoria. Then I'm going to be moving to the inspection of my patient's ears. Is that okay with you? On inspection of my patient's ears, there's no masses, lesions, drainage coming from the external canal with no erythema. I'm going to go ahead and touch your ears. Is that okay? Palpating the auricle. The auricle is firm, flexible, with no signs of tenderness. Palpating the mastoid area back here. No signs of tenderness, no pain. How about any pain here? Perfect. On palpation, no tenderness, no pain indicated by the patient. Next, I will be performing a whisper exam on you. Is that all right? So I'm going to ask you to go ahead and cover your left ear. I'm going to say a word and you repeat it back to me.
Basketball.
Cranial nerve 8 is intact with no impaired hearing loss for my patient. Next, I'm going to be performing an otoscopic ear exam of the external ear canal and the tympanic membrane for my patient. Is that all right? So I'm going to pull the auricle up and back because he is an adult male. I'm going to grab my otoscope, which is my pen light at the moment. On inspection of the outer external ear canal, there is no drainage, redness, lesions, or any signs of foreign body. Inspection of the tympanic membrane. It is white, pearly, transparent with no signs of perfusion, redness, swelling, And then the cerumen in my patient is yellow and oily as consistent with his ethnicity. The cone of light on the tympanic membrane shines at the 7 o'clock because of his left ear. It would be 5 o'clock on his right ear. Next, I'm going to be moving out of my patient's ears over to his nose. I'm going to ask my patient to go ahead and look at me. Patient's nose sits at the midline with bilateral symmetry of his nostrils. Patient's skin color is consistent throughout his whole body. I'm going to ask my patient to go ahead and look up. I'm going to inspect the inside of my patient's nose. There's no drainage, crusting, dryness, no signs of perforation, nasal polyps. I'm going to ask my patient if it is or polyps. I'm going to ask my patient if it's okay if I can palpate the nose and the sinuses. Is there any pain or tenderness here for you? No? Patient shows no masses or lesions on the external factors of the nose with no pain indicated by my patient. Next, I'm going to be moving over to my patient's lips. His lips have no dryness, no crusting, no exudate, no signs of any blisters. And then patient's lips are also pink, moist throughout, and it's just slightly darker than the rest of his body. Then I'm going to be assessing my patient's oral mucosa. I'm going to ask my patient to go ahead and open it up. I'm going to shine. Oral mucosa is pink, no lesions, no redness. I'm going to compress my patient's tongue, ask him to say ah. Perfect. Cranial nerve 10 is intact. Patient's uvula sits at the midline, rises and retracts when he says ah. Patient's tonsils are +1, hardly visible with no signs of redness. Next, I'm going to be assessing my patient's range of motion on his neck. So I'm going to ask my patient to do a few exercises if that's all right with you. Perfect. So go ahead and look at me real quick. I'm going to ask you to go ahead and say no for me. Chin to chest and then look up at the ceiling. And then can we do ear to shoulder for me? Perfect. Patient has full range of motion on his neck. Next I'm going to be assessing my patient's cranial nerve 11, which is the spinal accessory, by asking him to put some resistance on my hand when applying it to his cheek. Perfect. And then go ahead and shrug for me. Patient is able to apply resistance and show an intact cranial nerve 11. Next, I'm going to be coming down to my patient's upper extremities and performing a few examinations. So I'm going to check my patient's radial pulses. Radial pulses are equal bilaterally with a +2 rating with equal rhythm and strength. Next, I'm going to be moving to my patient's fingers. Patient's fingers, the fingernails are smooth, pink, and consistent in color, well kempt. Then they show blanching when pressure is applied. Capillary refill is within 2 seconds, and they return to the normal color. I'm going to assess the skin turgor. Skin turgor is skin is elastic, no signs of tenting or any signs of dehydration. Next, I'm going to be assessing my patient's angle of their fingernails. I'm going to ask my patient to go ahead and hold his nails up like this. There is the diamond formation, no clubbing evident, and the angle is less than 160 for my patient. Next, I'm going to be assessing my patient's strength of his hands. I'm going to ask him to go ahead and squeeze for me. Perfect. Now I'm going to ask you for the range of motion test. Go ahead and pull and then push away from me. Patient has full range of motion, equal strength bilaterally on both sides of my patient. Next, I'm going to be doing range of motion on my patient's hand. So I'm going to ask him to follow this exercise with me. We're going to do this. Go ahead and close, open, open more. Come back here. We're going to close our fingers, open, open more, extend our fingers, wiggle them. Perfect. Patient has full range of motion on his wrist and on his elbows. Next, I'm going to be performing a fine motor function skills test on my patient, asking him to do a few exercises. I'm going to ask you to go ahead and close your eyes, and then with each index finger, we're going to alternatively rotate, touching your nose. Perfect. Patient has fine motor function there. I'm going to ask my patient to go ahead and do alternate finger tapping on each side. Patient has equal fine motor function, no signs of difficulty when performing that action. I'm going to ask my patient to go ahead, supinate and pronate. His hands are on his lap. And then finally, we're going to be doing a nose to finger exam. So go ahead and touch your nose and then my finger and do it 4 times. Perfect. Patient has fine motor skills with no shaking, no tremors, and no difficulty when performing these actions. Next, I'm going to be moving over to my patient's thorax. My patient's thorax has no evidence of discoloration. The color is consistent with the rest of my patient's body. I'm looking at the AP ratio, and the AP ratio is 1:2. Patient has no signs of barrel chesting, pectus vacuomus, or pigeon chesting. Patient's costal-vertebral angle is at 45, and the costal-vertebral margin is at 90. Next, I'm going to ask my patient to go ahead and turn his back towards the camera. On inspection, my patient's scapula sits equally with, again, checking the AP ratio. It is 2:1. I'm going to be auscultating your thorax. Is that okay with you? Perfect. On auscultating the posterior of the thorax, I'm going to do 10 points on my patient, beginning with with the apex of the lungs. So I'm going to start up here. Every time I touch, I'm going to ask you to go ahead and take a deep breath. Could you cross your arms for me? Thank you. Go ahead and take a deep breath. Perfect. Deep breath. Clear and concise sounds. Come on over. Perfect. Patient shows no signs of adventitious breathing sounds, no crackling, rhonchi, stridor, or wheezing. Next, I'm going to be auscultating for my patient's lateral thorax, and I'm going to be asking my patient to go ahead and lift your arms. This is his left side, so there's going to be 3 points, and on the right side, there's going to be 4 points. So I'm going to begin on the left side, on the front. Go ahead and give me a deep breath. Perfect. Go over to the right, front, deep breath. The middle, deep breath. Perfect. Middle on the right. Back left. Back right. And then one more. Perfect. Patient shows no adventitious breathing sounds. There's no accessory muscles when breathing. No shallow or unlabored breathing is evident. Again, still no adventitious sounds. Vesicular sounds are heard throughout. Bronchovesicular on the second intercostal space on the posterior thorax. Now I'm going to be auscultating the front of my patient's thorax for his breathing sounds. Is that all right with you? I will be assessing the 8 points, starting at the apex lungs, again using the diaphragm. So I'm going to start off by, go ahead and give me a deep breath. Perfect. I'm going to move down, second intercostal space. Bronchovesicular sounds are heard here. Perfect. No adventitious breathing sounds, no accessory muscles are used, and the sound is clear and concise, just becomes slightly quieter when you're moving down. Next, I'm going to be inspecting my patient's cardiac landmark areas. When on inspection, again, it is consistent with the rest of the body, the skin color is. Then there is no visible pulsations or masses, no lesions are seen. I'm going to go ahead and palpate on your PMI. Is that all right with you? So, on palpation, I am feeling in the 5th intercostal space at the midclavicular line. Pulsation is felt at a +2 rating with no active heaves or thrills. I am going to be auscultating your heart sounds. Is that okay with you? Perfect. I'm going to be auscultating his heart sounds, beginning with the aortic valve with the diaphragm of my stethoscope. And the aortic is going to be at the right second intercostal space of the sternal border. Heart sounds are heard. S2 is heard slightly louder. Then I'll move to the pulmonic. Pulmonic again, S2 is heard louder. Normal heart sounds. I'll move down to the 3rd intercostal space. At Erb's point, no heart murmurs are heard. I'll move all the way down to the tricuspid at the 4th intercostal space. S1 is heard louder than S2 down here, and then I'm going to go to the midclavicular space, 5th intercostal, where S2 again is heard louder than, or S1 is heard louder than S2, but normal sounds are auscultated. I'm going to switch over to the bell of my diaphragm, and then I'm listening for the S3 and S4 sounds. At the aortic, I'm going to be listening for any S3 sounds after S2. Normal heart sounds, no indications of S3 being heard. Then I'm going to move to the Erb's point. Erb's point, there's no diastolic or systolic murmurs being heard. At the tricuspid area, there's no S4 after or before S1 is heard, and neither is there at the mitral valve. Next, I'm going to be assessing my patient's abdomen. I'm going to go ahead and ask my patient to go ahead and lay down. Thank you so much. On inspection, patient's contour is flat, no signs of hernias, masses, or lesions when looking at my patient's abdomen area. There's no visible pulsations or lumps. I'm going to be auscultating your abdomen. Is that okay with you? Perfect. So I'm going to begin with the right lower quadrant, auscultating for bowel sounds, and I'm going to do it with the diaphragm of my stethoscope. Coming down here, bowel sounds are heard every 5 to 30 seconds. Patient's bowel sounds are normal active, no signs of hyper or hypoactive bowel sounds. There's no borborygmi when not using my stethoscope. Next, I'm going to be percussing your abdomen. You let me know if there's any sort of pain. Is that all right? Perfect. On the right lower quadrant, I'm going to percuss 3 points. Moving to the right upper, I'm going to be percussing 4 points. Left upper, 3 points. Left lower, 3 points. Tympany is heard throughout, no signs of fluid retention, no signs of dullness or any enlarged masses or organs. Next, I'm going to be palpating with the pads of my fingers, a very light palpation. Is that okay with you? You let me know if there's any signs of pain or discomfort, okay? I'm going to be palpating down here. No signs of hernias, masses, or any pain or grimacing by my patient. Next, I'm going to be doing some deep palpations. Is that all right with you? I'm going to push down on the right lower, right upper deep palpation. The liver border is felt. Next, I'm going to move to the left upper, a very slight palpable spleen, and then the left lower, no signs of grimacing by my patient, no masses are felt, and no signs of enlarged organ. I'm going to ask my patient to go ahead and stand up, to sit up for me. Next, I'm going to be moving to the lower extremities of my patient. First, I'm going to begin with some inspection. I will inspect my patient's legs. On inspection, my patient's legs have no edema, no swelling, no redness, no lesions or excoriations. Looking down at the toenails are in healthy shape. They are pink and well kempt. I will be performing capillary refill on my patient's toenails. Squishing down, they blanch, or when applying pressure, they blanch, and then capillary refills within 2 seconds. I'm going to be assessing my patient's dorsal pedis pulses. Dorsal pedis pulses are at a +2. They are equal bilaterally and symmetrical in strength and rhythm. I'm going to be doing the posterior tibial pulses as well. Posterior tibial pulses are at a +1. They are felt slightly bilaterally. Next, I'm going to be moving up my patient's leg, and I'm going to be performing a deep tendon reflex test on my patient's patellar tendon. I would have a reflex hammer here, but I'm going to be using the belt of my stethoscope. If I would have him dangling his feet, I would strike the patellar tendon right below the knee, and that right there would have been a +2 rating and the expected finding with what I was performing. Next, I'm going to be doing a fine motor skills test on my patient's lower extremities. I'm going to be asking my patient, go ahead and tap your feet quickly. Thank you so much. And then I'm going to ask you to go ahead and run your heel to the shin on both sides. I'm going to be asking you to go ahead and perform a figure 8 with both feet. Patient shows fine motor functions with no difficulty performing these. There's no signs of tremors or shaking when he's doing this as well. I'm going to go ahead and now assess my patient's spine. So I'm going to ask him to go ahead and stand up for me. I'm going to be asking you to go ahead and perform a few range of motion exercises for me. We're going to rotate like this if you're cracking your back. Go ahead and put your hands to your side. Go ahead and rotate this way. Perfect. And then now we're going to go ahead and extend up and then flex forward. Perfect. Patient has full range of motion on his spine, no signs of difficulty and no pain when moving. Now I'm going to be assessing my patient's spine and scapula. Scapula sit at the same side or at the same height. Bilaterally and symmetrical, the spine comes right down the middle with no signs of scoliosis, lordosis, or kyphosis. You can go ahead and stand up for me right now. Patient's shoulder girdles are also at the same height with no signs of slouching or any signs of unevenness. Next, I'm going to be testing my patient's proprioception and his cerebellar function. So I'm going to ask him to come closer a little bit this way. What we're going to do now is I'm going to ask my patient to go ahead and walk to the couch and then come back, or right there, and stop right there. Patient's gait is normal with usual and expected arm movements, and I'm going to ask my patient to walk back, heel to toe. Perfect. Patient's heel to toe is normal with no imbalances felt. I'm going to ask my patient to go ahead or no imbalances felt or seen. I'm going to ask my patient to go ahead and lift one leg up, close your eyes for a Romberg's test. 5 seconds have passed. Patient shows a negative Romberg test and is able to maintain balance with no signs of poor proprioception. I'm going to ask my patient to go ahead and lift one leg up and then go ahead and bounce up and down. Patient shows intact cerebellar function and proprioception. So you can go ahead and sit down for me. Other than that, that concludes the whole exam. If that's all right with you, I'm going to actually lower you all the way down to the lowest height. I'm going to go ahead and put your side rails up. Your call light is right here. Do you have questions for me? Perfect. So I'm going to go ahead and take off the curtain, pull back the curtain, take off my gloves, perform some hand hygiene. I'm going to grab my equipment, head out the door, and then document all my findings. Thanks so much.